Welcome to this CTSNET interview with great innovators in thoracic surgery. My name's Joel Dunning, and I'm here at EACTS in Vienna with Diego Gonzalez Rivas. Diego, you worked in La Coruña, and you graduated in Santiago, and you are the creator of uniportal vats lobectomy. You went to America to learn vats lobectomy initially. Would you be able to tell me how you started in vats lobectomy and then how you graduated from a three-port technique down to what you do today?
We started the technique, the vats lobectomy, in 2007 in our institution. I went to visit in 2007 Rob McKenna, who was the biggest, the master of vats lobectomy. And I learned the technique there at CTSNET. And we started the procedure in our hospital in 2007. And after doing about 100 vats lobectomies, I decided to improve the technique. And I went to visit Memorial Sloan Kettering Center. And when I was there, I found a surgeon who was doing only 2 ports. And when he said to me, okay, I am doing only 2 ports. I'm from Duke. I say, this is not possible. How is it possible to perform a vats lobectomy by using only 2 ports? Yes, and he wrote me a paper showing the incisions. So I say, oh, I have to see this. So when I go back to Spain, I was thinking about, I want to learn this technique because it's less invasive. So I contacted Dr. D'Amico, and I went to visit him. I was short period of time seeing the procedures there, and when I come back to Spain, I started to do double port technique. So after about 95 cases doing the vats lobectomy with 2 ports, I realized that I was doing most of the time, because when you are doing double port technique, you need to exchange the camera and the staplers from one incision to the other incision. So what I did was, I was working most of the time through utility incision. And then I thought, why not put the camera through the utility incision? Because I have a direct view. Probably I have a better view. If I put the camera in the upper part of the incision and I work below, probably I will have better view and I can do the procedure as well. So I decided at the beginning in the lower lobectomies, because where this is lobectomies. And I did the first case in 2010 with no prolonged time, surgical time, so I was convinced about this approach, and I started slowly to develop the technique. At the beginning for lower lobes, but finally for upper lobes.
So I've not met many people that have invented a brand new operation. What was that first one like? Did you just didn't do 1 port, or you just thought, wow, I've done it for the first time through 1 port?
Yes, because I was very confident with the approach, and the view was very good. So it was what convinced me, because I was working in a sagittal plane. I read about before the papers of Gaetano Rocco explaining the concept of geometrical concept about uniportal vats. So I was convinced that this approach, working a sagittal plane, is like if you reproduce the open maneuvers, you mimic the open maneuvers inside the chest. It's the same concept. So what I learned to do was, I learned how to perform by manual instrumentation and work as I do in open surgery. We were trained in anterior thoracotomy approach, so it was a little bit easy for us, started with uniportal technique, because we have experience in double port technique and we have experience in anterior thoracotomy approach. So it was like a mixed concept.
Yeah, so for people sort of watching this, who do vats lobectomies, sort of thinking about moving to uniportal vats, would you say probably making sure you do an anterior approach and get down to 2, get down to 1 might be a very easy way to move to uniportal?
Yes, I think that it's very important, in my opinion, to have experience in anterior thoracotomy approach. It makes easy the procedure. It's like, if you are doing posterolateral thoracotomy and you want to learn the uniportal approach direct from open to vats, it's difficult because you work posteriorly. But if you want to learn the uniportal approach and you have experience with anterior thoracotomy, it's very easy. You only need to reduce the size of the incision, and you only need to learn how to watch the monitor instead through the incision. Of course, if you have experience in vats, in conventional vats, in double port vats, it's easier for you. of course. But it's possible. There are surgeons doing uniportal vats, and they learn the technique direct from open surgery, because this anatomic concept.
Yeah. So I've managed 3. Not sure I found it that easy, but do you think how important is it getting that single port correct in the right place? And certainly on some of your videos, the patients are a little bit up and the arm out. What's the best way to position for that very important one port?
Yes. Okay. The position of the utility incision of the incision is important. We always make the incision at the 5th intercostal space. It's a little bit lateral, more lateral position than conventional vats. But there are some tricks very important, like move the table anteriorly or posteriorly to place the lung, or put the patient in a Trendelenburg or anti-Trendelenburg position. That makes easier because it places the lung where you want. So here the concept, the most important concept is to expose the lung in a right position. It's very important, the exposure of the lung. The lung, the way you expose the lung is completely different than conventional vats. And this is the reason why you can't do every lobectomy, all the lobectomies, even advanced cases like post-chemo cases, like sleeve resections, chest wall resections, through an importal approach, because you need to expose the lung in a different way. The main advantage of this approach is that you have a direct view. And if you are using a 30-degree camera, you can achieve all the angles inside the thorax, because the conventional vats creates a torsional angle. It's a geometric explanation. And when you are doing a conventional vats, there's a end, there's a limit, because it's a physics explanation. There is an end. But when you are working in parallel, there's infinite, because the best line is a parallel line in terms of physics. So that's the concept that makes us continue, because we can achieve all the angles inside the thorax. We have no problems with division of the vessels of the bronchus, because if you have no enough angle for the bronchus or for the vessels, we have another options. We can put clips, we can rotate the lung, use the stapler in another position. So this is a different way to do the lobectomy.
So obviously in all new things, there are things that make it easy, and you travel the world, Colombia, Russia, and hundreds of other places, and I hear there are some instruments you don't leave home without. What do you think is absolutely vital to help you?
Well, okay, there are some instruments that are very important to achieve a successful uniportal vats lobectomy, and I always bring with me that instrument that I even today I have with me. There are instruments especially designed for vats. This instrument is the Gonzalez Rivas dissector. I designed
lived my whole life to have an instrument named after me, but
this instrument, it helps a lot for the lobectomy, for the uniportal approach, because it's a very light instrument with a proximal and distal articulation. Instruments like these, devices like lymph node grasper or scissors, that instrument helps to do the lobectomy through a single port, because you can put 3 or 4 instruments through a small hole. And when you open the instruments, you are not fighting, because the articulation is distal and it's proximal. So these instruments helps a lot. And the most important is that during the learning curve, you learn how don't fight with your partners. Because at the beginning, if you are using conventional instruments and you open the conventional instruments through the incision, you are fighting because you have no enough space. But here, through a small hole, you can use 3, 4, even 5 instruments, and you don't fight. So it's very important to learn the technique with the optimal instruments. It's very important to have high-definition cameras.
Do you always use 10mm cameras?
Yeah, we use 10 millimeters because we think that the view is better. The field is wider. But we have the 5 millimeters also, and sometimes we use the 5 millimeters. But in my experience, I prefer the 10 millimeters.
Have you ever used the adjustable cameras? Have you tried them?
I tried, but I think that with 30 degrees is enough. You don't need more angles. You don't need because sometimes when you try to use new devices or new cameras with more articulate scopes, you have another view, maybe it will be more difficult for the dissection. So you only need 30 degrees because you make the rotation of the scope, and with the rotation of the scope, you can achieve all the angles. So I think it's not necessary that, but maybe many surgeons can help.
And obviously, it's annoying when blood drips down. What about a lovely Alexis tissue retractor, just to get all that out of the way?
Well, I don't need that retractor because I think, in my opinion, the soft tissue retractors like Alexis reduce the angles, because you have 1 centimeter inside the chest, one plastic centimeter device inside the chest. So when you put through the hole and you need to achieve these blind areas, if you had 1 centimeter here, you have no enough angle, and you press. And I think this could cause more pain. So, and not only the pain, the angles are reduced. So it's the reason why we don't need to use Alexis retractor. It's not necessary. We perform all the cases with no soft tissue retractor. Maybe it could help, but not in our experience.
Yeah, and I suppose one thing that really helps is actually having some clips for branches when the angles aren't quite right with the stapler.
Yes, I think that the clips helps a lot when you have small branches. And also the energy devices, the Shilland devices, maybe the harmonic or other devices helps a lot, especially for lymph node dissection. And the scopes, I like the scopes, the thoracoscopes where the CCD is in the tip of the scope. So you don't need a lateral light, and you don't need a plastic bag to protect the scope. So this is, it helps because there's only a straight thoracoscope, and you have more space to work. You don't need to be fighting with the plastic bag. Retracting the plastic bag covering the scope. So there are some tricks that helps the performance of uniportal vats lobectomies. But like in any procedure, I always say that you need to learn the technique, because there are some surgeons doing conventional vats that they say, okay, let's try to do uniportal vats. They try 2, 3, 4 cases, and they say, oh, no, this is dangerous. Oh, I don't like it because I have no angle for the vessel, for the artery. Oh, this is dangerous. I prefer the conventional vats. This is not the right way. You need to go to see centers with experience and stay there and learn the technique, watch videos, read the papers, the atlas, and then you can do it, the uniportal vat symmetry. It's like if you are doing thoracotomy and you want to learn vats. So, I want to learn vats by myself. So probably it will be a disaster. So you need to go to learn the technique, and once you learn the technique, probably you are convinced, and you need a learning curve like in any procedure.
Yeah, and there's little tips, isn't there, like for upper lobes, get the artery before the vein,
Exactly.
things like that you only see by that. And you've certainly got a few videos out there. I mean, your video is unbelievable, the extent and amount of things you've done uniportally. I mean, what's the limit? And tell us a few of the things you've done, and what do you think the limit is?
Well, I think the limits for bats in general, there are no limits for bats. Because at the beginning, 10 years ago, 15 years ago, probably there were a lot of contraindications for bats. But nowadays, with experience, there's no contraindications for bats. Maybe if you have a tumor of 20 centimeters, it will be a contraindication. But nowadays, sleeve resections, chest wall resections, even angioplastic resections are performed by bats. So with the uniportal approach...
Left atrial.
Yeah.
Peel it off the left atrium. That scared me, that video.
So actually, there are no contraindications. And with the uniportal approach, we have performed very advanced cases. We have done sleeve resections from the right side, from the left side, angioplastic, like vascular reconstruction, even chest wall. So I think that the limits are in the mind of the surgeon.
Yeah. Do you ever convert? I mean, apart from bleeding, because we all have the odd one, but is there anything that you go, this will be easier open, or not in?
Well, if you have to convert, I think it's not a failure. I always say that. But nowadays, most of the bleedings can be controlled by
apart from that, do you ever go in and you go, oh, this will be easier open, I'll convert, or hardly at all?
Well, okay, if I have a very complex case, I will open direct. But every case I try by bats.
Yeah.
Because
That's
you
great.
know there are a lot of cases that you think that cannot be performed by bats. But if when you put the scope inside and you explore the cavity and you say, oh, this is possible, so you avoid the thoracotomy. So I think it's important to start all the cases. I think all the cases need to be started by bats.
Yeah. So I use you quite a lot as an example of a great innovator, because in the old days, someone thinks of a new operation and, you know, you do some cases, you compare it to your other one, you write a paper that's a day difference, but yourself, you've got out there, you've got videos, Twitter, Facebook, you've got all these amazing resources. And it's only 3 years old, your operation. I mean, where do you think the place of changing towards science, trying to get studies, or do you think it's like TAVI, where, you know, you do it and it's so great, you know, let's just show by trying?
Yes, because what you know, what we are doing now is only to reduce the size, the number of ports. So we are not doing a new procedure like, you know, if you are doing a new oncologic resection, maybe you need a study, of course. You need a randomized trial, or you need some studies to know if you are doing an oncologic right procedure. But if you are doing the same as you do in open surgery, you know, it's like what are we doing is a lobectomy and a lymph node dissection, but we are reducing the size of the incision. So you don't need studies, you don't need randomized trials, because if you do complete lymph node dissection, and we are completely agree that with the scopes, with the high definition scopes, you can achieve a more radical lymph node dissection. So I think that the need for studies now are no, there's no place for studies to compare open thoracotomy against bats, with bats, or conventional bats with uniportal approach. Maybe you can do a study to know if the pain is less. Probably will be less, because you don't use the trocar and you don't compress the nerve. But I think that we live now in a different moment than in the past.
Yeah.
There are a lot of ways to promote and to show the techniques, and I think that is very important, because it helps people to do it. In the past, if you wanted to learn some technique, you need to go to the atlas to see the drawings. But now you go to internet, you go to YouTube, you go to the video atlas in CTSNET or in other, or annals as ACS. So I think it's very important to spread the knowledge and to share with the colleges.
Yeah. And do you see any great new innovations coming up in the future? What do you think will be next? There's a lot of amazing single port general surgical instruments and things. Where do we go next?
Well, I think that the future of the thoracic surgery, in general of the surgery, comes with the robotic technology. I'm convinced about that. Probably not the actual technology. The robotic technology available now is not appropriate. Because there's only one company, they have the power, and probably they don't want to develop at this time all the technology. But there's no doubt that the technology will improve, and the new equipments are pushing and are developing the single port robotic technology. Probably the future will go with single port, with open arms inside the thorax. You can work like in a parallel instrumentation with even with wireless cameras, because the future will be the minimal invasive techniques. There's no doubt. And if you can do all the procedure through a very, very small hole with open arms inside the thorax and work, sitting very comfortable, in a very comfortable seat. You can work with, all instruments, maybe staplers like, very thin. Probably will be the future. So now there is some prototypes of single port robotic techniques I have seen last week. There's open arms inside the thorax. I think that the new techniques, the new wireless cameras, probably I don't know, nano robots put it inside the thorax, and they work by remote control. I don't know, but I'm sure that the robotic technology will be the future, because we live in a new era. So the advantages of the robots are clear, but they need to improve. Nowadays you don't have tactile feedback, but you will have, sure. They will develop the tactile feedback, and they will develop the wireless cameras and the small arms, and probably there will be some systems to analyze the specimen inside the thorax, probably, and remove like liquid, through a small hole. I'm sure.
You've got swallowable cameras already, haven't you, in gastro, and
yes.
just drop one in. That's technically possible, isn't it?
We have to be open to this. We have to be open to the future. We cannot say, okay, I'm confident with my approach and I don't want to learn the new techniques. Of course, I don't use robotic technology at this time, because if you use robotic today, you need to use 3-4 ports, and you spend more money, in my opinion, and you use more holes, so it's more aggressive. I only use one 3 or 4 centimeter incision, and we finish the procedure in maybe 45 minutes. So I don't need the robot now, but I agree with the robot.
Yeah, one day
I believe in the robot, and I will try to learn the robotic technology and the robotic approach when it's correctly designed for minimal invasive approach through a single port.
Yeah.
I will learn.
Yeah. So I came on your fantastic course that you run in La Coruña, and it was just wonderful. I had lamb models, and we all practiced the Uniportal with you guys trying to help us through it, and then you had some brilliant live demonstrations. And I believe you're doing a course next year as well. Do you want to tell us about?
Yes, we have in La Coruña a technological center. This is an experimental center where we perform every year about three uniportal courses. So we will have the next course in October and the next in December. But in February 2014, we will do a uniportal international symposium that will be with 3 days course. The first day will be international symposium, uniportal vats, with a lot of international speakers coming. The second day will be live surgery. We broadcast the surgery through an auditorium, and also we will broadcast the course worldwide, online. This will be some innovative concept.
Yeah, so if people can't come, they can actually sit at home.
Yes.
And go onto livethoracic.com, isn't it?
And then the name of livethoracic.com.
Yeah.
And we are trying to to expand and to share this concept of uniportal vats around the world.
But then they don't get a nice evening dinner or a look at some nice cars in the evening, eh?
Of course.
Well, it's been an absolute pleasure. It's a fantastic operation, and it's taken the world by storm. So, Diego, thank you very much for coming to talk to us at CTSNet. So from everyone here, myself, Joel Dunning, thank you very much.
Thank you very much.